So my topic is epidural and caudal epidural steroid indications, contraindications, technique and complications. So what I'm supposed to say is whether use it steroid, whether we use steroid, because it is a era, or it's a era long standing ongoing debates that whether we will use steroid or not, whether steroid is to be used very frequently. It has got so many adverse effects, whether it should be used with local anesthetic, without local anesthetic, and so many. So let's go and start some journals and meta-analysis, which is let's start with comparison of clinical efficacy of transforaminal and caudal epidural steroid injection in lumbar and lumbosacral disc herniation, which is a meta-analysis. They say that clinical benefits with transforaminal epidural steroid injection is better than caudal epidural steroid injection because it has the ability to deliver the medication directly into the target area. But the evidence is very low. So next journal is, it was published in British Medical Journal, effect of caudal epidural steroid or saline injection in chronic lumbar radiculopathy, multicentric, blinded, randomized control trial. But surprisingly, they say that caudal epidural steroid or saline injections are not recommended for chronic lumbar radiculopathy. So we will go to another paper, which is caudal epidural steroid injection to randomized control trial. They said that caudal epidural is effective because it is technically easy to give, low complications than other techniques, and so it is interestingly more demanding in case of management of low back pain and sciatica. Another study which says that the evidence for effectiveness of epidural injections in managing chronic spinal pain range from limited to strong. So they found that for lumbar radicular pain with interlaminar lumbar epidural steroid, the level of evidence was strong for short-term relief and limited for long-term. For cervical pain, the evidence was moderate, and the evidence for lumbar transforaminal epidural steroid injections for lumbar nerve root pain was strong for short-term and moderate for long-term improvement. So it has been found that the evidence for short-term relief is more than the long-term relief. So there is always a confusion how frequently we will give the steroid injection. So why for the long period we always discuss about the giving steroid? Is it a magic drug? So let's to answer this question, we have to go to the background of the degenerative disc disorder. Previously, it was said that there was imbalance between catabolic and anabolic factors, which is obsolete nowadays. So nowadays it is said that there are some changes in the nucleus pulposus that causes the decrease in the synthesis of type 1 and 3 collagen and more in type 2 collagen and more synthesis of the type 1 and 3 collagen, also increase in the membrane metalloproteinase activity, ultimately degradation of the extracellular matrix and proteoglycans. So the integrity of the nucleus pulposus is lost, that ultimately fissure occurs in the annual ring, and the extrusion of the nucleus pulposus, generation of pain due to compression of nerves. But pain can also occur in the early stage of disc degeneration in the absence of nerve compression. Why? Because of inflammatory mediators, and that causes the the inflammatory process helps us to conclude to give steroid in degenerative disc disorder from very early stage. Now this schematic representation exactly shows what I have told just now. Due to low oxygen, low glucose, end-plate calcification and some adverse load, the disruption of the disc due to changes in the structures of collagen synthesis. Now, protease, cytokines, and neurogenic and angiogenic factors, along with nerve fibers and blood vessels, are present in human degenerative discs. So, long-acting steroids is helpful. Now, I will not discuss about the cervical thoracic because it is only 6 minutes I have. So, directly I am going to the lumbar epidural indication. Radicular pain resulting from irritation and inflammation of the dorsal root ganglion and other neural structures in its vicinity. Refuse surgical correction of the disc disorders. Mainly, these two indications are there, and contraindications are significant bleeding diathesis, systemic or local infections at the procedure site, and severe degenerative changes. So, technique, I will mention about the transforaminal because we often use it in our day-to-day practice. After all those consents and stopping anticoagulants and all those, what we target is the safe triangle. So we should put our C arm first in the true epi position. Then we would try to square the vertebra by cephalic rotation of the camera. What is the squaring of the vertebra? The vertebral margin should be in line. The anterior and posterior surface should be in the line. Okay, in the single line. And then we will rotate the C arm in the ipsilateral oblique view to cover the, to superimpose the transverse process with the vertebral body so that we can see the pedicle. Because our target is the Scotty dog. And below the pedicle, at the 6 o'clock position, we would first insert the local anesthetic and subsequently the spinal needle. And we will enter the needle with the end on view with the camera of the C arm. So once we enter the space, we would change the position of the C arm and make it lateral. And we go by millimeter with the lateral view, because if we go very fast, we can puncture the dura. So we will stop before a C line comes and we will apply the dye, what is iohexol or romantic or whatever. So in the lateral view, we will get a streak of a line, and in the anterior-posterior view, we will get a C-shaped line like that. So it is the transforaminal epidural injection. I collected some video from my institute, but due to some technical issues, I could not put it in my slides. I'm sorry for that. So next, I'm going to the caudal epidural. So see, the dural space at the caudal area is very close to the sacral bone. So we should go from downwards. We should insert our needle from the downwards and go very carefully. See the indications. It is herniations or spinal stenosis, sacral nerve root scarring, coccygodynia, rectal pain, pudendal neuralgia, sacral fracture, post-radiation sacral radiculopathy, sacral metastasis, and post-spinal surgery syndrome with pain not responding to the conservative management. The contraindications are infection, altered coagulation, first trimester of pregnancy, arachnoiditis, and etc. So, in case of caudal epidural, patient prone, pillow under the abdomen to remove the exaggerated lumbar lordosis. Fluoroscope should be in the lateral view from very first. Epi view we will see later. So we will first try to identify the sacral hiatus, because our target is the sacrococcygeal membrane that corresponds to the C2, C3, 4 vertebral junction. It varies according to the body structure. So we will proceed till the C line comes and just stop before it again in the lateral view. We will go again millimeter by millimeter to prevent the inadvertent puncture of dura. Now I will push the dye, and in the lateral view same, streak a line, and in epi view it will show inverted, what is called inverted fir tree appearance. Complications are hypotension, perianal numbness, and sacral nerve root injury. Spinal cord injury due to localization of large volume of injected. See, for if we give more than 10 ml of hypertonic saline in case of caudal adhesiolysis, we may injure it. Then avascular necrosis, bladder bowel dysfunction, bleeding, hematoma. In some cases, maybe rectal injury, because all the structures are very close to each other. So I will thank my institute for the picture or images I have taken, and thank you for your patience. Have a good day.